My name is Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Next, I'd like to discuss radiation therapy and how it can be used to treat breast cancer. Radiation is a particle or electromagnetic wave moving at high speeds near the speed of light that carries sufficient energy to detach electrons from atoms in tissues, thereby ionizing these atoms. And the atoms that make up the DNA in cells are particularly vulnerable to this ionization effect of radiation. So radiation can induce DNA damage capable of killing cells, including both cancerous cells and also normal cells, it's important to point out. So this is an important, powerful tool that is used in cancer treatment, especially in breast cancer. Radiation therapy or radiotherapy is therapy using this ionizing type of radiation, generally as a part of cancer treatment to control or kill malignant cells, and is normally delivered by a linear accelerator machine. Radiation therapy may be curative in a number of tumor types, particularly if they are localized to one area of the body. Also, it may be used as a part of adjuvant therapy to prevent tumor recurrence after surgery, to remove the primary malignant tumor, particularly, for example, in the case of early stages of breast cancer. Medicine has used radiation therapy as a treatment for cancer for more than 100 years, with its earliest roots traced from the discovery of X-rays by William Röntgen in 1895. Indeed, Emile Grube of Chicago was possibly the first American physician to use X-rays to treat cancer, beginning back in 1896, treating thousands of patients and treating many physicians on the use of radiation therapy as a treatment for cancer. Ironically, Grube himself died of cancer due to occupational exposure to X-rays, unfortunately. Radiation therapy is commonly applied to cancerous tumors because of its ability to damage the DNA of cancerous tissues, leading to cell death. To spare normal tissues of this fate, such as the skin or organs, which the radiation must pass through to get to the tumor target, specialists use shaped radiation beams aimed from different angles of exposure to intersect at the tumor, providing a much larger absorbed dose than surrounding healthy tissues. And so that can mitigate against toxicities to surrounding normal tissue and focus the beam particularly on the tumor bed itself. Besides the tumor itself, the radiation fields may also include the draining lymph nodes if they are clinically or radiographically involved with tumor, or if there's thought to be a risk of subclinical malignant spread indeed. It is necessary to include a margin of normal tissue around the tumor to allow for uncertainties in the daily setup of radiation therapy due to internal tumor motion, for example, movement due to respiration while the patient is breathing during treatment sessions, or even in the pelvis, you have to consider bladder filling, for example, because the level of urine can change the anatomical location of tumor targets, for instance. It's also common to combine radiation therapy with surgery, with chemotherapy, hormone therapy, or even immunotherapy, or some mixture of all of the above. Very large tumors respond less well to radiation compared to smaller tumors or microscopic disease. Various strategies are used to overcome this effect. The most common technique is surgical resection of the primary tumor prior to radiation therapy. This debulks the majority of the visible tumor and leaves behind micrometastases, which are more amenable to radiation effects. This is most commonly seen in the treatment of breast cancer with lumpectomy to achieve clear margins, or even mastectomy followed by adjuvant radiation therapy. Another method is to shrink the primary tumor with preoperative chemotherapy prior to radical radiation therapy. That's another avenue that can be explored to optimize effects of radiation. The main side effects reported from radiation are fatigue and skin irritation, kind of like a mild to moderate sunburn in many cases. The fatigue often occurs during the middle of the course of treatment, but it can actually persist even for a few weeks after the treatment ends because the effects of radiation may continue on for days to even a couple of weeks after the completion of all the radiation therapy sessions. The irradiated skin will heal, but it may not be as elastic as before. This situation is called fibrosis, that is, tissues that have been irradiated tend to become less elastic over time due to a diffuse scarring process. Similarly, sweat glands in treated skin tend to stop working after radiation as well. And occasionally lymphedema can occur, a condition of localized fluid retention causing tissue swelling, can result from damage to the lymphatic system sustained during radiation therapy. But it's less common from radiation therapy, let's say to the axilla, as compared to axillary dissection surgery, which has a higher risk of lymphedema than radiation even. It's commonly reported that complications from breast radiation therapy in patients who receive adjuvant axillary radiotherapy following surgery, that is the lymphedema problem, can be seen in those patients. And second cancers can occur following radiation therapy, but they're very rare. And they usually occur late, usually at least 4 to 6 years or even longer following treatment, although some hematologic malignancies may develop within the first 3 years or so, but those are even more rare. A very rare complication of radiation to the breast is the development of another cancer called an angiosarcoma. In the vast majority of these cases, this risk is greatly outweighed by the reduction in risk conferred by treating the primary cancer in the first place. Radiation near the heart can also theoretically increase the risk of cardiovascular disease, and radiation near the lung can also cause some lung damage called pneumonitis. Radiation to the breast can sometimes damage some of the nerves to the arm, leading to what's called brachial plexopathy, which can cause some numbness, pain, or weakness in the shoulder, in the arm, or in the hand. This is also uncommon because it's screened for during follow-up sessions. In rare cases, radiation therapy may weaken the ribs, which can also rarely lead to rib fractures. These usually heal spontaneously on their own, are often asymptomatic, but can be picked up on x-rays or CT scanning following radiation treatments. In contrast to external beam radiation therapy, radiation can sometimes be given directly into the tumor bed during surgery. This is called intraoperative radiation therapy, or IORT. The rationale for IORT is to deliver a high dose of radiation precisely to the target area with minimal exposure of the surrounding tissues, which are displaced or even shielded during the IORT session in the operating room. If you've had a mastectomy and no lymph nodes had cancer cells, radiation, if clinically indicated, can be focused on the chest wall and the mastectomy scar, although in many cases radiation can be avoided in lymph node negative disease following mastectomy. For patients treated with breast conserving surgery, you'll most likely have radiation to the entire breast, called whole breast radiation, and an extra boost to the radiation to the area where the cancer was initially removed can be used to help it prevent recurrence in that location. The boost is often given after the treatments to the whole breast have ended. It uses the same machine with lower amounts of radiation aimed just at the tumor bed. Most women don't notice differences in side effects from the boost compared to that of the whole breast radiation. If cancer was found in the lymph nodes, especially under the arm, this area can also be given radiation as well. In some cases, the area to be treated might also include the lymph nodes above the collarbone, the so-called supraclavicular lymph nodes, which means above the clavicle, and the lymph nodes beneath the breastbone, the sternum, in the center of the chest. The internal mammary lymph nodes sometimes may be considered by radiotherapists for radiation therapy as well. The standard schedule for getting whole breast radiation is 5 days a week, Monday through Friday, for almost 6 weeks typically. Another option is called hypofractionated radiation therapy, where the radiation is given also to the whole breast, but in larger daily doses, also 5 days a week, but using fewer treatments, typically lasting only about 3 weeks. So that may be an option for consideration in selected patients. In carefully selected patients, some doctors are using accelerated partial breast radiation to give larger doses over a shorter time to only one part of the breast compared to the entire breast. More research is needed to know if these newer methods will have the same long-term results as standard radiation treatments. I hope that this brief introduction to radiation will be helpful to you in your practice and for patients who are in need of radiotherapy for primary breast cancer treatment. And hopefully my comments will be helpful to you in your clinical practice or in your treatment plan if you're a patient when adding radiation to the therapeutic armamentarium, along with other modalities, surgery, systemic therapy, and now radiation as well. Thank you very much for your attention.